Our keynote panel brings together leaders from across industry, academia, policy, and lived experience to help frame the future of AI for mental health. The discussion will focus on responsible deployment and defining clear, actionable priorities for the field. Our moderator for this panel is Dr. Carolyn Rodriguez, who's Professor of Psychiatry and Behavioral Sciences and an Associate Dean for Academic Affairs here at Stanford University in the School of Medicine. She's also co-director of our AI for Mental Health initiative. I'd like to welcome up to the stage Dr. Rodriguez, as well as the folks who will be joining her for this keynote. So Dr. Adeli, Mr. Brendan Staglin, and also Dr. Vaile Wright. Come on up.
All right. I'm very excited to kick off and this keynote panel. Just to set the stage, we have 3 speakers, and each is going to talk for about 5 minutes, and then we're really excited to get your questions and comments. We're going to have a Slido ready, and there'll be a QR code that you can submit questions. So one of the things that is incredibly heartbreaking, and the World Health Organization has published new updates, is that there is an incredible shortage of mental health care workers. And on median, the massive treatment gap is the median healthcare is 13 workers per 100,000, and in low and middle income countries, it's less than 2 per 100,000. And yet LLMs are used, active users are in the over 500 million range, and worldwide individuals, used by individuals is in the billions. And so presents an exciting moment where technology is available. How can we use it responsibly? And our speakers today are going to give us some nice examples and kick us off from across academia, foundations, and professional organizations. So Dr. Ehsan Adeli is an assistant professor of psychiatry and behavioral sciences, and by courtesy, biomedical data science and computer science at Stanford. He directs the Stanford Translational Artificial Intelligence, or STAY Lab, and co-directs the Stanford AI for Mental Health initiative. And his research bridges computer vision and computational neuroscience with an emphasis on connecting human motion and behavior to neural mechanisms that regulate movement. Recently, his group has developed ambient intelligence technologies to detect and delineate neuropsychiatric and behavioral systems at home. And his team has also developed multimodal large language models to evaluate and align clinical fidelity and safety in therapy chatbots. Brandon Staglin, he is a OneMind co-founder, chief advocacy and engagement officer. He channels his deep experience in leadership, advocacy, and his personal schizophrenia recovery to drive mental health innovation and community engagement to heal lives. With years of successful advocacy for science-driven advances in early intervention for youth facing severe illness, he has emerged as a champion for the elevation of lived experience-based guidelines to shape the future of mental health systems. His current work focuses on assisting employers to successfully hire, retain, and benefit from the unique skills of workers with lived mental health experience. And finally, Vaile Wright, as the inaugural Senior Director for Healthcare Innovation at the American Psychological Association, where she leads national efforts to advance the responsible use of technology and data in mental health care. A licensed psychologist and nationally recognized expert, Dr. Wright develops strategies to expand access to care, strengthen quality measurement, and modernize mental health service delivery. She's a trusted voice in federal health policy with research published in leading peer-reviewed journals and is a frequent contributor to the national media. She earned her PhD from the University of Illinois at Urbana-Champaign and is licensed to practice psychology in the District Columbia. Without further ado, Ehsan.
Thank you. And maybe...
Oh, yes. And so you can scan this QR code and I will see your questions.
Perfect. And we also have running mics in the room as well. Okay, awesome. So thank you, everyone. Thanks, Caroline, for the introduction. And also thanks, everyone, for being here this early in the morning. And maybe for many of us, even before finishing our first cup of coffee. Anyways, so I'm sure everyone now knows that AI is everywhere, specifically LLMs, and we are using those for our for many everyday purposes. Even some people consult AI before or sometimes instead of seeing a doctor. And this is true for physical health and even more so for mental health. Some studies found therapy and companionship is now one of the most prevalent use cases of LLMs. And I want to highlight our very own HAI just published their 2026 AI Index report a couple of weeks ago, in which they explained experts predict 10% of US adults will use AI for companionship at least once per day by 2027. And this is predicted to rise to 30% by 2040. The top quartile of experts actually forecast that this is going to be more than 40%. And again, this is daily use, every single day. And I think these numbers are staggering. Another report hot off the press is the AI safety report by Stanford's very own Center for Digital Health. It was published just last Friday, yesterday of the working days, and in which experts outlined what harms chatbots cause, how they can be measured, and how these measurements can help improve safety. So AI is being used for companionship and even entering therapy. But clinical quality is more than sounding empathic. A model can sound warm, but still fail clinically. Good therapy requires agenda setting, guided discovery, risk recognition, escalation, and appropriate safety boundaries. That's what motivated us to develop Therapy Gym, a new paradigm for building clinically grounded cognitive behavioral therapy chatbots. We first built a multi-turn realistic benchmark annotated by expert CBT practitioners across 9 clinical skill domains and 4 safety measures. From the benchmark, we derived a structured rubric for evaluating conversations against therapeutic skills and safety standards and trained a judge model. Then we fine-tuned open source chatbots using reinforcement learning, injecting therapy skills and safety awareness directly into the model. And the resulting chatbot showed measurably improved clinical communication skills and safety consensus behavior. Just the showcase of how these systems could actually work. Zooming a little bit out, while popular culture tends to equate AI with chatbots and LLMs, it's worth emphasizing that AI is a much broader field. LLMs gave us linguistic intelligence, but language is only one channel. Mental health is expressed through voice, face, movement, behavior, sleep, physiology, environment, and brain activity, to just name a few. Multimodal AI will shift the lens from what people say to how people feel, behave, and change over time. And I believe the next frontier of AI will be multimodal, behavioral, spatial, and physical AI. We've been building systems in collaboration with our very own Stanford Adult Hospital, creating these physical intelligence and behavioral intelligence models. And we've tested those for detecting and understanding neuropsychiatric symptoms in senior living facilities over the course of a month. So NPS are behavioral psychological changes such as depression, anxiety, and others that you see on the slide. Our system, by passively monitoring daily activities in participants' homes, it learns to identify subtle changes in behavior and physical function, as well as movements of breakdown. The ultimate goal is to enable early preventative interventions for individuals at risk of dementia and related conditions. This type of technology creates many opportunities by enabling more objective measurements between visits, building personalized and adaptive interventions, and providing better support for clinicians and caregivers. Our early results do show high efficacy in detecting the moments of severity for each symptom automatically, passively, and more over extended periods of time. And with that, I just want to conclude by reiterating that I believe AI in mental health will be moving from chatbots to multimodal clinical intelligence. And when it comes to LLMs alone, I don't think the question is, can I sound like a therapist, which most of the models are trying to do right now. The real question is, can I support safer, better, and more equitable mental health care? Thank you.
Great. Brandon, love to hear from you.
Yeah, thank you, Carolyn. Thank you, Ehsan, for kicking us off. Is my mic working? Can you hear me?
Yes.
Awesome.
Yes.
Yeah, good. So with recent advances in AI, the world of mental health and the world of communication is looking more and more like science fiction. In fact, there are scientists now that are currently developing AI that can potentially even become conscious within a few years' time, as I'm reading about Michael Pollan's most recent book. So truth can be stranger than fiction, even science fiction. Who here is a science fiction fan? All right, fair number of people, it's okay. Yeah, it's only acceptable. I'm a science fiction fan. Who here remembers the great science fiction writer Isaac Asimov of the golden age of science fiction? Yeah, fantastic. One of my favorite quotes from Isaac Asimov, who is, by the way, my teenage hero, I wrote a term paper on him in high school, is never let your sense of morals prevent you from doing what is right. What does this mean? It seems like a challenge, like a riddle. Well, I'll give you a hint. So in this age of increasing complexity of our society and of the mental health fallout that results, lives are at stake, and technology can be a double-edged sword in that battle. So I'm going to illustrate the point that I'll bring you to in terms of interpreting what that means with a personal story. So I've lived with schizophrenia for 36 years. And one of the worst times in my experience with schizophrenia was right after my second episode of schizophrenia in 1996. I was about 26 at the time. I had been working as an engineer here in the Silicon Valley at that time for about 4 years, building satellites. And I had a relapse. I had gotten into graduate school. I knew that I had to sleep less than 9 hours per night to succeed in graduate school, so I went off my schizophrenia medication. And it was a devastating choice. I had to resign from that job. I couldn't work. And I had to go back into the psychiatric hospital. And my morale was crushed. My confidence was shot. And my faith in myself was in the tank. And my social skills really suffered as a result. So I had to move to San Francisco to live close to my psychiatrist, to be able to see him twice a week for therapy sessions. And living alone in an apartment in a big city, not knowing anybody in the environment there, not being able to make friends, was really difficult. I was so lonely in that time. And I learned from that experience that human relationships, deep in-person human connections, are essential for mental well-being. At that time, technology presented itself to me with two opportunities. One of them was the advent of massively multiplayer online role-playing games, which can be a way to socialize, and I had been a gaming fan at the time, but I was wary of them because the socialization that takes place online is fundamentally thinner and less rewarding than that takes place in person. So much more richness in in-person interactions. So I wanted to develop deep in-person relationships, and being sucked into the world of role-playing games would not afford me that, so I avoided that technology. The other opportunity was cognitive remediation training. which was a new innovation at the time for schizophrenia treatment. I participated in an experimental study of cognitive remediation training through UCSF for about 2 months. And in so doing, I used a computer program that helped remold my neural pathways in my brain to rebuild my social abilities. Within 6 months of doing that training, I was back at work, back enjoying time with friends again. It was a breakthrough. And the first novel that I had the concentration to read again was an Isaac Asimov novel, by the way. It was a great relief. So technology is a double-edged sword. How can we ensure that technologies like AI cut in the right direction? So it's essential that we make these technologies in a way that, of course, as has been said, ethical, safe, responsible. But we must not let overregulation slow down the pace unnecessarily, because lives are at stake. So how can we navigate this conundrum effectively? Well, science is essential to do this, and scientists all around us are doing this, and you're doing this as scientists. But it's essential also to listen to people with lived experience of mental health conditions. And we're doing that at One Mind right now, my organization. So One Mind is a program called the One Mind Accelerator. There are 2 members of our accelerator team here today, Ali Alford, seated over there, and thank you, Ali. Sarah Schneider, who's also here, the senior director, seated somewhere here. Yeah, great to see you, Sarah. Thank you. But this program is helping entrepreneurs that develop technologies such as AI-based technologies to help people with mental illnesses in a variety of ways. It's been a very successful program, but we're guiding them in part through our lived experience initiative, which I lead at One Mind, connecting them with people with deep lived mental illness experience, as well as deep experience in fields related to mental health professionally. So we're guiding them to target their products and services at real human needs based on our perspective on the ground. So far, we've guided 14 companies through One Mind's accelerator cohorts over the last 3 years to do this. We're guiding 5 more to form their own lived experience councils coming this year to propagate our model outward. And thank you, Ali, for helping us do that. And I'll give some examples. So last year, one of our cohort members was Slingshot AI. Derek Hull from Slingshot spoke here in April. And we're very proud of what they're doing, in part with the accelerator's guidance and our guidance, to target their chatbots' focus in helping people toward developing agency and human relationships, not just relying on the AI. Another example is Biomia, a company we're helping form a lived experience council this year, developing medications for schizophrenia using AI to interpret organic molecule structures. So we're excited to develop this work further. If you'd like to learn more about what we do and engage with the lived experience community to help develop your technologies, please contact me either during the symposium or after. So, never let your sense of morals get in the way of doing what is right. Hope we have a better sense of what that means and a conviction to do what is right for people struggling with mental illnesses. Thank you.
Well, thank you so much.
There's a moment where it's going to happen. Good morning, everybody, and thank you, Brandon, for sharing. And as I said in the prep call, these are very difficult people to follow, and so I will do my best. But just to sort of recap, I mean, we've heard about the fact that we are experiencing a global mental health crisis. So it's not just here in the US, it's across the world. We've also heard about the workforce shortage, and if you really want to see the numbers and striking graphs, go to HRSA. They actually have mapped out the workforce across all of behavioral health. And you can see that the demand for services and the supply of providers, the 2 lines never meet. We've also heard about really incredible advances from scientists like here at Stanford on the promise that AI can have to help address this crisis. And I'm here to tell you that we have not met that yet. And I think that the opportunity that we all crave and hope that exists, I worry may never happen, in part because while we don't want a regulatory system to impede innovation, we cannot have healthcare advances without a modernized regulatory system that engenders trust in these products among providers, among patients, and almost more importantly, among payers. Because if we truly want equity in our way of addressing the mental health crisis, we have to be able to pay for it. And we can't pay for it if we don't have tools that payers will pay for. And that's the reality. So how do we get there? What do we do? I think we need to partner, right? We need to partner between payers and regulators and legislators and scientists and people like Brandon and myself to help create tools that will actually move the needle and have impact. The other thing I worry about is, the challenge with the mental health crisis is so much bigger than AI, yet AI is taking up almost all the air in the room. And so what I worry is that we're not talking about all the other solutions that we need to implement in order to address the systemic problems. And instead, we're spending a lot of our time, in some ways, spinning our wheels talking about AI. But here's the reality. This is what we're talking about. In fact, there's probably people in the room right now on their phones. There's certain people online on their phones. I was on a panel the other day and somebody was talking too long. I was a speaker. I was reaching for my phone. So what does it mean when our number one relationship is with a device? When instead of purpose-fitted tools being available and scalable, people are turning to general purpose LLMs to fill the gap in their emotional needs. In fact, I was sitting on a plane the other day and somebody was asking an LLM whether they should buy a house. These are the things we used to talk to our friends about. So I think that yes, AI has promise. Yes, we need to figure out how we partner to create better technology. But I also think there's an existential question here as well. How do we put the value add back into human-to-human relationships? How do we mindfully think about our relationship with our devices, with AI? And how do we really realign our experiences with our values in a way that reminds us that human relationships are what make us us? We absolutely do not exist without them. Because this is what I see right now. So I'm looking forward to having a discussion about it. Thanks.
All right, so now we're going to open it up for questions, and we'll put up the QR code again. But just to start us off, several world leaders have recently and very prominently talked about how human dignity can be preserved with AI. Would love to hear from each of you how we can center the human experience in AI and live up to that potential. Whoever would like to start.
Great, and maybe
Start?
Sure. Yeah, I mean, I think the fact that you've seen, for example, Pope Leo come out and talk about AI, it speaks to the global nature of this, right? Even though many of the frontier models are built here in the US, it's clearly a larger global issue. And I think that part of how we keep the human dignity or the humanness in it is not just human in the loop on the user end, but it's really keeping humans throughout the process, throughout the entire developmental life cycle. And I think that in order for us to really understand technology that's built by humans for humans, you have to have the experts on humans at the table. And that is behavioral health scientists, right? And having them not just, again, as sort of your end user, but really throughout the entire process. I meet with a lot of startups in my role. And often they are very well-intentioned in what they want to do. And it's in part because everybody has a mental health story of some sort, right? Either yourself or a family member or a colleague. And so they want to build with that in mind. And I ask them, well, who are your clinical SMEs? And they say, well, we don't have any, right? We were going to figure that part out later. There's no later. It has to be at the front end. It has to be at the start. It has to be your subject matter experts, your individual lived experiences. It has to be not just your technologists.
Thank you, Vaile. That's a great answer. And I'll add on to that by building on what you said about involving lived experience in that as well. So when you involve people with lived experience in co-developing solutions for technological mental health, you are bringing in insights that clinicians do not generally see if they don't have their own lived experience. So I'll give an example. So in One Mind's Accelerator program, one of our very first cohort members was a company called Motif Neurotech. It's a company developing minimally invasive neurostimulation devices that are implantable on the skull to treat using like TMS for depression. And to charge that small device implanted on your skull requires the use of a battery and a charger for the battery. And the charger is interfaces with the battery through a cap that you put on your head. And when the company developing Motif was developing it, they were very fortunate to have the guidance of a lived experience council, which my friend and fellow member of One Mind's Lived Experience Council member, John Nelson, was serving as the director of that Lived Experience Council for Motif. And because of his guidance and that of the other members of their council, they were able to understand that the cap should not be something worn at night, because people are afraid that it'll be like pushed off when somebody's asleep and they turn over and they won't get the charge they need for their neurostimulation device, which would be a disaster for their mental well-being, but rather something they wear during the day. So they decided to make the cap very stylish, something that people would be proud to wear and be seen with. This diverted the course of the development of that product because of a lived experience-based insight that could not be seen any other way. So involving people with lived experience, as you mentioned, will be a critical component of AI development, just as it is for any mental health solution development.
Thank you so much. There were several questions that you answered about that, about lived experience, and questions specifically for you on giving some examples. So thank you so much. Another question for you, Ehsan, or others is, how can models themselves be evaluated for safety?
Yeah, that's a great question. And something I wanted to very briefly also add, I think it was a great question answer to the previous question, but I think that the idea of co-design is something that everybody's looking into right now in the AI for mental health space. And in the next series of talks that we have today, I think I've looked at the agenda, we have very good talks around the very topic. When it comes to safety and evaluating and understanding the different measures, concerns with respect to either chatbots or any of these AI models, one of the things that always comes to mind is how can we annotate or label or see if actually one conversation is safe or not, or one of the items that is coming up in the chat is a safe direction, instruction or not. So there are so many different ways of doing this in the AI world. Even at Stanford, we have this AI Safety Center for AI Safety, where they are developing formal methods for evaluating AI. But the thing is that when it comes to psychiatry and mental health, many of these tools become not that useful because we don't have formal ways of measuring or annotating safety. When it's a subjective measure, there are lots of challenges in building those formal methods for evaluation. So we have to be creative. We have to build things similar to what I present at Therapy Gym, trying to annotate data and see if we can make sense of data with respect to those subjective measures or not. And there was also a great discussion that Killian was talking about, bringing all of these different stakeholders together to be able to define some of these measures. So anyways, with respect to safety, I think it does require bringing in individuals from both AI and clinical sides, defining the measures that we can use some of those more formal methods of evaluation. But as I said, we have to be smart and try to build systems that can also evaluate safety and other skill concerns with all of these subjectivity that we have in the measures.
Thank you. All right, another question from the audience. AI should augment and not replace scarce clinicians, but the economic pressure pushes the other way. What's the actual guardrail that keeps augmentation from quietly sliding into substitution, especially for underserved populations who already have the least access to a human?
Matt?
Yeah.
So
Thank you.
I would question that question and state that there may not be a better solution to reach people who have no access to a clinician at this point. But you can build in guardrails into AI-based tools that can keep people safe. So I'll give an example from a paper I recently read. AI-based tools, chatbots, for example, can sometimes cause people to dissociate, to lose touch with reality if people have deep conversations with them on an ongoing basis for months or years. And if people are already at risk for psychosis, then it's a double risk at that point. So if you can build into an AI-based tool something like a psychiatric advance directive, so like when you start to use an AI-based tool, have the person define what they want the AI tool to do if they begin to dissociate. Perhaps contact a friend, contact a family member, contact a clinician, or alert them that they're beginning to dissociate and remind them to introspect and compare how they're feeling and how they're behaving with how they did before. This can be a method to prevent people from the danger that could otherwise result with an AI-based tool. Another factor would be similar to what I described earlier, using the example of the Ask chatbot, where it doesn't prioritize engagement with the app itself, but rather forming those human relationships outside of use of the app and giving people the tools and skills to do that effectively. So those are two examples of how to address that, I think. Any other thoughts?
Sure, yeah. I used to say AI is not going to replace therapists. I now think that AI will replace therapists for those who are never going to seek out a therapist in the first place. There will always be a room for therapists, and I think that the reality is we need to absolutely be rethinking what our system of care is. That we can't just expect everybody to go to weekly 45-minute psychotherapy, because while that's what everybody deserves, if that's what they want, that's not necessarily what everybody needs. And so we really need to be thinking about how do we actually meet the needs of the individual who's either in front of us or, again, never going to walk through our door, but is still suffering and needs something. Now, unfortunately, I would argue the technology is not good enough yet, and we have to make the technology better. But I do think that there is a role for it to in some ways go beyond augmentation. And I'll give an example, a personal example. I learned recently that my stepson, who now just finished his third year of university, but in his first year was trying to find a therapist and couldn't find one. I would have given anything for him to have a digital option that would have been successful and impactful and helped him. Because the reality is he just suffered on his own. And that's what we're talking about here. And when I give talks to other psychologists who say, well, can't we just find them a person? I said, no, you don't understand. There aren't enough people. So we do have to figure out what are other solutions. And again, as I said at the beginning, technology is not the only solution. It's one of many. And so my hope is that since we're having so many conversations around AI, post-pandemic, and more focus on mental health than ever before, that what this really does is crack open a conversation about the system itself and how we impact that.
Okay. Meg, chime in. Thank you. That's a great point about how we need to reform the system and look at it in new ways. We need to augment what the system can do, including through AI tools, but in other ways too. So for example, peer support is an incredibly effective part of mental health care. And even people who are not trained peers can learn skills to listen effectively. Listening can be a really powerful healing tool if it is done in the right way, if it is done non-judgmentally, if it is done supportively, if it's done appreciatively, and with referral to some sort of form of mental health care when that's needed. I can give an example of a time when a peer listened to me and it redefined my concept of myself. I've been struggling with an experience I had had in a creative writing class about a memoir that I wrote, very vulnerable memoir, and having it trashed by my fellow students. And that really crushed my confidence in my ability to write and in my interpretation of the experience that I wrote about, which had been a very formative experience for me. When a peer, who was actually my mentor, somebody else with schizophrenia, his name was Robin Cunningham, he passed away about 4 years ago, amazing person. He listened to me telling that story to him, and in so doing, he just listened, and in so doing, I was able to redefine the meaning of that experience and reclaim the value of that initial experience for myself and rebuild the confidence that that experience initially engendered. So listening can be really powerful, and peers can be an essential component of that.
And just to add a quick great answers and very good examples, just to add one more of the examples of use cases of AI in this space, I want to highlight the fact that we could use AI, as some of my colleagues in the Create Center and also in the computer science department are building and developing AI systems that can help clinicians by simulating, for example, patients instead of just simulating the therapist. So there are so many different other use cases that could be considered here. I'll stop here because there was a great discussion on this topic, and we can probably move on.
Wonderful. And actually, maybe, Ehsan, how can we think about AI in mental health beyond chatbots and LLM? Do you?
Great, yes.
Examples?
Thank you, yeah. So I tried to show a few slides on this topic because I needed those visuals showing how with AI tools we could go beyond language. As I said, chatbots focusing on language, bringing in the linguistic intelligence. That is a very good front door to understanding people's state of the mind. But what we argue is that mental health is bigger than that. Again, it's a lot of human behavior, interaction with others, interaction with the environments that defines mental health. At home, for example, the moments of breakdown are those that are very good indicators and symptoms of mental health disorders, which we call them neuropsychiatric symptoms. So other types of sensory data, sensory tools like wearables or even ambient contactless sensors can help us understand the behavior, have better ways of measuring behavior in a more objective manner. These are tools that could be used over extended periods of time, noticing changes in behavior and having the information ready for the clinicians when it's the time of annual visits of individuals, for example. Because in annual visits, we often are always given these forms of have you had any changes in your behavior, mental status, and so on. We always tend to select no, all of us, because even ourselves or those who are living with us, they don't very much measure or understand the changes. These changes are so gradual that are often ignored. And sometimes even they are stigmatized very much similar, very much especially for older adults, in the case of older adults, because that's associated with age and often not reported. So these tools, these AI models paired with proper sensory pairing could measure some of these symptoms passively. I'll stop there. There are so many other examples, but that's that's the part that was related to my own research.
Okay, for any of you, what kind of public health systematic educational approaches might our society lean into to ensure people develop healthy skills for interacting with chatbots?
Yeah, I'll start. So I was just down in Santa Barbara yesterday doing a walk, a fundraising walk for my organization, One Mind. I met some amazing people down there. One of them was a gentleman named Dino Ambrosi, who's a professor at UC Berkeley, who as an undergraduate in college had a life-defining experience with phone addiction. He'd just gone to a new college away from his home and kind of a culture shock for him. And he had difficulty making friends in the new environment, so he gradually turned more and more to social media, to feeds, and to search on his phone to find something to do and a sense of companionship or engagement. And he realized after about a year of constant phone use that he was addicted to it. So he Googled phone addiction. There was nothing on it back in 2017, no studies. So he took it upon himself to start to study the phenomenon and develop ways to address that for himself that can be translated for other people. Since then, there have been studies that have been done on it, and he's leveraged those as well to develop a curriculum at UC Berkeley, which he taught as an undergraduate through a program they have for undergraduates there called DECAL, to his fellow students. And now he has a program there as a faculty member called Project Reboot, where he works with young people, trains them to go into schools in the community and talk with young people, about healthy technology use, including social media, including AI. They're developing the curriculum around that now. And to give them the healthy skills they need to maintain their relationships, their agency, and so forth as they engage with technology. Another example is broad-scale public health educational systems. So my niece and nephew go to a school in my community in Napa it's a Waldorf school. Who has heard of that model of education, the Waldorf model? Yeah. So they prevent the kids from using phones as they're growing. They don't allow that anytime during the week. But they teach them through experiential learning, through hands-on projects, team-based with their peers. And from this, they develop skills to interact with other people successfully and healthily. And this can give them what they need as they start to interact with technology down the line, have them like well-suited for that and ready. My niece and nephew are great kids. They have great manners. When they visited my wife and me about a month ago, my nephew was saying, when we served lunch, he was saying, no, Tia Nancy, that's my wife, you eat first. You get the food first. So, and he was 8. So I was really impressed with that and the kind of education he's getting. Those are 2 examples.
Yeah, at APA, we've been putting out some health advisories geared towards mostly the public, but they also have recommendations for policymakers, for researchers, and others. Our most recent health advisory was on the use of generative AI and wellness chatbots to try to start this, campaign of helping individuals understand not that chatbots are bad, right? Because they're there, and saying that they're bad and to not use them is not effective. But to help people understand what AI is good at and what AI is not great at. I do think the problem is much broader than that. So at APA, we also did a study of university professors asking them if they thought it was their responsibility to help their students understand how to use AI, and they universally said no, that it was not their job. Right? And so I think we need a mind shift, right? And we need to start thinking about, what is our responsibility to ensure that future generations know how to use this technology successfully, given that it's not likely going away, right? You do have still calls for sort of, just it to disappear, but I don't think that's going to happen. So how do we think about our job and what happens ethically if we don't help future generations think about how this technology could be helpful or not helpful. So I think there's a lot of work ahead of us to be done. And I'm not sure who's going to step into that, but I love those examples of what you have. I think that that probably that grassroots approach is going to be how we start, but I don't think that that's sufficient. I think we need something broader.
Mm-hmm. And just to double check, does anybody in the audience have any questions? Feel free to raise your hand and as well. Give folks a moment. Yeah, go ahead.
Thank you for sharing and all the stories. Amazing. Question for Dr. Wright. You mentioned today's technology is not good enough. Curious, what do you see missing, and what does it look like when it's good enough? Thank you.
Question.
Well, I'm going to start by saying I'm not a
Key question.
technologist. So let's preface it with that. I mean, I think the fact that individuals turn to general purpose LLMs over purpose-fitted options suggests that something about the purpose-fitted options, whether it's cost or just lack of accessibility or something else, means it's not meeting whatever need they need, right? Like they're choosing to use a no-named general chatbot instead of Ash, right? Which is built by clinicians for clinical purposes, and yet people are not using it, right? So I think, and even in those examples, right, where you have some promising research, right, for Ash, for Therabot, for some others, there's a reason people aren't turning to them, right? And so that to me suggests that the technology just isn't where we need it to be. Now, that being said, the elephant in the room is therapists aren't as good as they need to be either, right? So that's sort of the conundrum. The real conundrum is quality. At the end of the day, the conversation we probably really need to be having is the quality conversation. How do we have better quality technology? How do we have better quality human-to-human therapists? And part of that comes down to evaluation and measurement in ways that we're not doing currently. And so that's my long about way to not answer your question.
I think you did a pretty good job. Anybody else? Yeah, go ahead. In the center there.
Thank you so much for sharing your experiences. And I'm going to lead into this question with a self-disclosure. I have anxiety, and I also build mental health for AI. And so I'm really grateful for hearing from people who have lived experiences on this panel. So one of the things I've been struggling with the most is understanding how to handle AI refusal when I'm building my technology and making sure that I'm actually getting people who refuse to use AI for a variety of reasons in my research. 1 in 5 Americans use AI. Most of them don't, or at least they're not admitting on surveys that they're using it, and they're probably not counting the summary at the top of Google as using AI. And the thing I worry about is we've got a lot of plausible reasons why people don't want to use AI. They believe it supplants human relationships. They're worried about water use or data consumption or giving their information to a chatbot provider that they can't even control these. And while I'm very positive about the ability for AI to transform mental health care, I also don't know myself how to integrate this concern that might be coming from actually a majority of people who want to see more ethical and safe and like pro-social development of AI fundamentally before it can even touch mental health. And so I'm curious for the whole panel, how do you think about working within people who are more skeptical of AI use? And how would you integrate those concerns into the development of AI systems so we could actually reach that 80% of Americans who say that they don't use AI?
I'll start it. Yeah, thank you. Great question. So I'll go back to the answer I'd given before, but in a different way. So when you co-create products with people from a community that's going to use the product, they're more likely to trust it than if it's created by people in an ivory tower or in a corporation, or it's perceived that it's created that way. So if companies developing AI, like your startup or even large AI developers, would partner with the community that they're aimed to serve in very visible and very real ways, that will help build the trust. And people will see that the solutions are relevant for them and have their best interests in mind. So that is one way to start to address that I think could be effective.
I mean, I think if we're talking about AI for healthcare, right? So not AI for just, right, for anything else, but for healthcare, I still think it honestly comes back to regulation. We would not just say, here's a new SSRI, let's test it out in the public before actually having sure that it actually is effective, right? Yet we've done that with AI. And so what we have now is a culture where AI companies have made real mistakes in real time. And now we're trying to course correct. And I think that's fundamentally the challenge here. And so I do think that our regulatory system is clearly flawed. It needs to be modernized, as I said at the beginning. But it is what we have. And so I'd rather see us try to work with the system that we have in place and improve it than to continue to circumvent it the way we've been doing, because I think that has caused a lot of the lack of trust and the concerns that people have.
All right. Thank you so much. I know we have a lot of questions. I didn't even touch the ones on Slido. There's going to be time for a lot of discussion in between panels. But what I'd like to do now is maybe just ask a theoretical question and have each person give their either answer the question or maybe a parting thought that they would like people to get away from our session. So the question is, if you had a magic wand and you could magically change one thing to improve AI for mental health, what would it be? Or any parting thoughts? Ehsan.
I would make it a little bit more objective so we can build algorithms.
Good. It's an easy question, right?
All right. Yeah, no, I would make sure that it's co-developed with people's lived experience and guides people toward their peers to help them through those real relationships.
I think similarly, what I would want is for AI technologies to bring us back to humanity and to human relationships, as opposed to bring us away from them.
All right. Thank you all so much. Thank you for your wonderful questions. Thank you to our panelists.